Well, welcome. My name is Dr. Chris Campbell, owner and physical therapist at Sport and Spine Physical Therapy. Today I have the great pleasure of having Dr. Moby Parsons of the Knee, Hip, and Shoulder Center of Portsmouth, New Hampshire. Welcome, Dr. Parsons.
Thank you.
So today we're going to talk about Dr. Parsons' program that they call the Avatar program, a same-day surgical procedure for doing what usually takes 1 or 2 hospital stays. And they've been finding significantly greater outcomes in various things like reduction in infection, quicker recovery time. Here we are to have Dr. Parsons start us out and telling us exactly what Avatar means and what it is.
So Avatar really was pioneered by my partner, Dr. Thomas King. And so he and his physician assistant, Kathy Levitt, are really due a lot of credit for generating the foundation of this program, and I've been lucky to join them in practice and be able to apply this to the surgeries that I do, including knee, hip, and shoulder replacement. Avatar is an acronym that stands for Alignment of Vital Assets to Accelerate Recovery. And I think what we've realized over the years is that the surgery itself is really just one portion of the entire care process. And historically, surgeons have put great emphasis on the surgery and then come to realize over time that if you don't emphasize all the other elements of patient preparation, patient education, prehabilitation, optimization, nutrition, stress management, infection prevention, and all these other elements that can go into the care, including dedicated physical therapy, you can wind up with a very well done operation, but a patient that is not happy with their outcome. And so it became clear to us that we had to engineer this care pathway better so that we could take all these, what we call assets, and align them along the diagnosis. So for instance, if you know you have a diagnosis of knee arthritis, needing a knee replacement, we have a very good idea of what assets go into that process of care and how we can optimize them and really customize them for each individual patient to make sure that they get the best outcome. And so that was kind of the genesis of the Avatar program, was to break it down into what those assets were and then work with each of those people internally to the care system and optimize each one of those assets, customize it for the patient, and then really focus on the end goal of the outcome. What we noticed as we've gone through this process is that it is a very process-oriented thing, and you can get a little bit lost in the weeds of going through the process when really what the goal is focusing on the outcome. So we took sort of an outcomes-oriented approach, saying we know what we want for these patients. We want rapid recovery. We want excellent range of motion. We want them to be able to manage their pain very well. And then we sort of worked backwards through the assets to figure out how we could get there. Over time, what this has enabled is patients to recover much quickly, so that for patients who are candidates, they are able to go home the same day and recover in the comforts of their home. So we have patients who can leave the hospital literally within 3 to 4 hours of having a knee, hip, or shoulder replacement, go directly home and recover in the comfort of their own home. And we found that there are benefits to that, including being more comfortable, probably getting better sleep, being able to manage their pain in real time, and potentially a lower risk of infection because they're not surrounded by, potentially other patients who may have medical illnesses that raise their risk of infection. So Avatar really is not specifically an outpatient care program, but for the patients who are able to and interested in it, allows them to go home because of the rapid recovery approach.
Excellent. So when do you make that decision for who is appropriate for the Avatar program or going home with same-day surgery?
So we try to really use the Avatar program in everybody, regardless of whether they're going to go home or not, because we feel that accelerating the recovery is important no matter where people wind up after surgery. To be a candidate to go home, you definitely have to have support at home, so you can't go home alone. So it's helpful to have spouse, friends, or family who can be there for the first few days. And you generally have to be healthy enough that you have no medical problems that need to be managed during a hospital stay. Now, many of our patients do have chronic medical problems like hypertension or diabetes or coronary artery disease, but most of those medical problems have been stably managed over time and can continue to be stable after surgery. So while there are some hard cutoffs for patients that can't go home if they have, unstable coronary artery disease or congestive heart failure or significant chronic obstructive pulmonary disease or lung issues and make it hard to breathe, those are patients that we may definitely want to monitor overnight. But a lot of people, even if they have stable hypertension, stable heart disease, can go home. And we've had patients go home into their 80s. So it's not just something that young people can do. Motivated patients who want to get home early, even in their 80s, can definitely do this and do it very safely. And what we've seen is that if you educate patients in advance and you prepare them for this and you get everything lined up before surgery and you get them optimized with pre-rehabilitation, many of them can do extremely well with very low risk of readmission to the hospital.
So talk about some of the prehab and the responsibility on the patient, the 24, 48, 72 hours prior to surgery, as well as the month or so leading up to it. What are the expectations and what kind of emphasis do you place on the responsibility of the patient moving into this avatar?
Yeah, so I think one of the key things is, patients have to take a very active role in their own recovery. So when patients come to us and they're at the point where they have made the decision to proceed with surgery, we spend quite a bit of time with them really getting their mind focused around this process. And we like to call this patient activation. You have to activate that patient to get involved in the care program and to really do what we call own your outcome. Patients have to be committed to this. And if they're not ready to do this, they won't have a good outcome. So we make sure that patients are really committed and really motivated to do this. And I think the earlier you can start, the better. The things that we like to start with, 6 or 8 weeks before surgery, definitely emphasis on nutrition optimization, get their immune system boosted up. We like to put people on vitamins and minerals before surgery, like zinc, vitamin C, vitamin D, vitamin B, vitamin A. All of these things have been shown to strengthen immunity and healing. We like people to try to lose weight if they can, which has also been shown to reduce surgical stress. There's various antioxidants, if people start eating more fruits and vegetables, that can also boost healing capacity, lower the stress response of surgery. So these are things that the modules that we have on our website can go through some of the sort of dietary practices that people can make to try to really get their body in the best shape possible. Then as far as exercise is concerned, this is what we call prehabilitation or pre-rehabilitation. As you know, there's great evidence to suggest that if patients can strengthen the muscles around the joint to try to get as much range of motion as they can beforehand, even to strengthen their upper body if they're going to be on crutches or a walker after surgery, those are the things that can make their life easier after surgery, speed up the recovery of their muscle function, and get them off assistive devices earlier and help them to succeed going back to a home environment earlier. And those are things, obviously, the earlier they start it, the better. As we get closer to surgery, we focus more on home preparation, get rid of anything that can be a fall risk in the house, throw rugs, electrical cords, things of that nature, make your ice packs beforehand. And so we have a little primer on how patients can do that. They can stock up their fridge with meals, they can get all their bills paid. What we like is when patients come into surgery, everything is taken care of and all they really have to do is show up. We like to get patients all their medications that they'll need post-operatively. We set all that up in advance. We set up their physical therapy in advance so they know where they're going to go and when they're going to get there. Those appointments are lined up already in advance. So the more preparation patients do on the front end, the less they have to do on the back end. And then really in the sort of 1 to 2 to 3 days leading up to surgery, we have some infection prevention things that we do with antibacterial soap. We start a bowel regimen and a pain management program because if you preload the body with those things, people tend to do better post-operatively. And then, the final thing that we tell people to do is try to get a good night's sleep before surgery. And really try to relax. It's I've been through this, as you're probably aware. I've had joint replacement surgery myself. It's a scary prospect to think that you're going to have to undergo these things. But to the degree that people can sort of put their mind at ease before surgery, get a good night's sleep, and sort of trust in the process, and I think really when patients have invested in it, put a lot of work in on the preparation end, they can feel comfortable coming into surgery, that they know they're in the best shape possible, and that helps them to relax.
Well, it definitely seems like there's a lot of components that go into it, that, as you said, are the responsibility of the patients going in, even before they've had surgery, before they're even going into your facility, by getting alignment with their support people at home, somebody that's not only going to drive them home, but that's going to be there, all the prep work that they're going to do, filling their fridge with food, ice packs, getting the strength, the weight loss, the nutritional aspects. It sounds extremely thorough, but as I said, it's all driven by the research that you guys have found and the best outcomes for that patient. Those things are what you guys are seeing with your particular practice, that the outcomes of Avatar are exceeding what you had prior to putting this program together?
Yeah, it's amazing when patients get invested in their own recovery, what they can achieve. And so while we would love to take credit for all this, I really think it's a team process. And obviously, I think the work that you guys as physical therapists do is also really critical. Obviously, we're fairly selective where we like to send patients. You being one of those people that we have targeted as a great therapist, I think that makes a difference to sort of have a team approach and to everybody to be aligned on what the expectations are. I can't emphasize the patient education enough, and we're very fortunate to have a team of physician assistants and nurse practitioners that work with us, that know this program very well, know what kind of investment it takes, and can spend a great deal of time with the patients to really get them on board. And that's one of the things that patients will tell us is, I felt like I knew everything going into the surgery. It made such a huge difference. And the time that you invest in that is time that's incredibly well spent. So I like to say that patient education is really the blockbuster drug of the sort of new century, more than any medication that we give people. Patient education is really the blockbuster, and when patients know what the expectations are, they can really achieve great outcomes just by knowing exactly what's involved in the recovery and being motivated to do it. So with all these things put together into a coherent program with the patient education and with our sort of rapid recovery approach, what we see is at 3 weeks, many patients are at a level of recovery that we used to see, at 6, 8, 10 weeks after surgery. So it feels like to us what we're seeing in the office when patients come back for their post-operative visit is that they're much further along than what we would see, 3, 4, 5, 6, 7 years ago, in terms of, getting rid of pain, getting rid of swelling, getting range of motion, getting off of assistive devices and getting back towards daily functional activities. And that's a lot of fun to see, because obviously for patients, these are things that they want to get back to, and the quicker that they can get back to them, the happier they are. And then when they start seeing the progress, then I really think they begin to trust in what they can achieve. It becomes a kind of synergistic energy.
Great. So some basics, I'm sure our viewers would like to know some of the time frames. So roughly, say with a total knee, when would you say that they're getting off crutches through the Avatar program on average?
Yeah, it's really variable. And I think this is the key thing for patients to understand, is that everything that we do, there's a spectrum. There's a bell curve, and there's always the 50th percentile. And you're always going to meet the patient that was in golf balls, 4 days after surgery. And then you'll meet the patient that struggled along for 4 months before they could hit golf balls. And there's a lot of unknowns that go into how fast patients recover. But we tend to talk in averages or generalizations. And typically what we see is patients can sort of lead from crutches or a walker to a cane, anywhere between probably 3 to 4 days and 2 weeks. And it really is variable, just depending on how strong they are going in, their sort of preoperative level of fitness and function. And some of it too is how fast they get their muscle function back. As you've probably seen, some people do get to muscle inhibition after surgery, and other people seem to have great muscle activation right away for reasons that are clear. I think it's generally in that time frame, with the avatar approach and better quad sparing mechanisms and muscle sparing techniques that we now do. I think there is a little bit less muscle inhibition, and that allows people to get off assisted devices faster. I think pain management has a lot to do with it as well. And keeping people comfortable after surgery allows them to move around more safely and just better when patients are struggling with pain.
So the Avatar program is appropriate for patients that have arthritis of the knee, the hip, and the shoulder. So you're doing replacements on all three of those joints?
Yeah, I started off my career really as a shoulder specialist and was one of the first people in the area doing shoulder replacements. And then when reverse shoulder replacements came to the market in 2004, I was the first person in New Hampshire to start doing those. And then I morphed my practice over the years into one of doing joint replacement of the upper and lower extremity. And just by sheer numbers, because hip and knee arthritis are orders of magnitude more common. And now I do more knee replacements and hip replacements than shoulder replacements. But I'd say 90% of my practice is those three operations. And this is a program that can really be tailored to each recovery. Obviously, they're different because they're different joints and they have different restrictions and different time periods for when people can do various different things. But one of the nice things about the Avatar is that the principles, the underlying principles remain the same. And then you can just tailor the assets to whatever it is you're doing and customize them to whatever those patients' needs are. So that's one of the nice things about the program is that you can customize it to each patient.
And as far as the pain on an Avatar program versus traditional replacements, have you seen any less postoperative pain through your patients?
Yeah, I think pain management, it's an interesting topic, and I think some of it is probably driven a little bit by patient expectation. So I think if you can do a really good job getting patients a solid understanding of what their recovery is going to look like, they're able to cope with the discomfort better than somebody who is sort of caught unexpected, post-operatively when it's kind of too late to educate them. So I think the more you can give patients a very concrete, realistic picture of their recovery, I think that gives them much stronger coping mechanisms. We don't lie to people. We tell them this is orthopedic surgery and it is uncomfortable and we expect you to have some level of pain. But that said, we do have a comprehensive pain management program that I think really keeps it at a level that's manageable for people. And so they're not ever at that extreme where things are sort of, dire. And what that involves is using a combination of medication together that works synergistically so that the additive combination works much better than any one of these medications by themselves. So routinely patients will tell us, well, Tylenol doesn't work for me or Advil doesn't work for me. And that may be true by itself, but if you combine Tylenol and Advil, and we use a non-narcotic pain medication called Tramadol, we'll oftentimes use something called gabapentin, which is a nerve medication that can reduce nerve pain. We'll sometimes use muscle relaxers. These are all non-narcotic medications that can be used safely together. And when they're used together, they can synergistically reduce the overall level of pain without having some of the bad side effects of opiate pain medications like constipation, nausea, drowsiness, and some people can get hallucinations. And so what we try to do is use the non-narcotic pain medications as much as we can and then use the stronger narcotic pain medications only as needed. 5 or 6 years ago, it was pretty routine that we would do a knee replacement on somebody and give them a script for 90 oxycodone after surgery. And oftentimes they would need to refill that prescription, a couple of weeks later. Now we oftentimes only give people 20 to 30 pills, and many people come back and say, I only took 10. And I think it's because this comprehensive what we call multimodal or many different medications works incredibly effectively. And preloading the body before surgery, which is something that we do by starting Tylenol and gabapentin preoperatively, makes a big difference. The other thing is we use regional nerve blocks during the surgery so that the joint that we operate on is relatively numbed up at the time of surgery. And we use a long-acting local anesthetic, whether it's a hip, knee, or shoulder replacement. There's a medication called Exparel, which is a local anesthetic that can provide 48 to 72 hours of relief. So when patients wake up from surgery, they don't have that acute rebound pain. They're relatively comfortable, which allows them to immediately mobilize and get up and start walking. And all those things have major benefits on reducing stiffness, which then causes less pain. And so we give people a very comprehensive spreadsheet before the operation that lays out the schedule that we want them to take these medications. And we make sure that they have a great understanding of it. And they leave with the schedule in hand. And the patients who really stick to that do remarkably well. And we have many patients come back saying, I just took pain medications for 3 or 4 days and then I didn't even after that. Some patients will take them, before they do certain activities. Many times we'll recommend people maybe take one before they come in for therapy so that you guys can get more work out of them. But by and large, people aren't requiring the same level of heavy pain medications that they did in the past.
So with a proper, again, education, management, setting up proper expectations, you're seeing, again, through this program that there is a different mindset that they're having post-operative with their pain, and therefore have a little better buy-in and understanding, again, that this is orthopedic surgery, that they will have some pain, but you're seeing significant less medication that needs to be taken afterwards.
I think the buy-in can't be emphasized enough. When patients kind of buy into the process and have a really good understanding of it, it's just immeasurable the benefit that has on people afterwards in terms of being able to manage expectations. I think the other thing that really helps is we keep in very close contact with our patients. And so we routinely will call them the day after surgery and sometimes 2 or 3 days later and check in with them and really make sure that they're doing okay. And if there's any questions or concerns or problems, we can kind of head those things off at the pass before they spiral into a bigger problem or a catastrophe. And, it really helps, again, reinforce the education, because sometimes patients post-operatively can get scared if they have a symptom that they weren't expecting, or if they have swelling, or if they have discoloration around the joint. Those are things that if you don't know, can be disconcerting for patients. And so, just simple phone calls to the patient to check in and sort of reinforce some of these patient education expectation things, and also just provide reassurance makes a huge difference too, I think. And so that's one of the things that we pride ourselves on as part of this program is communication with our patients, and communications with therapists, with visiting nurses, and ancillary providers. We routinely hand out our cell phones and say, send us a picture if you're concerned about the appearance of the wound. Send us a picture, call us if there's a problem, call our office, call our cell phone, just call us. And I think that's really key. You can't just do the operation and walk away. You really got to support people through this process. And if you provide excellent support and a safety net for people, they can really do great.
Now, is there a cost difference on the Avatar program compared to traditional replacements?
Absolutely not. I mean, if anything, what I would say is because patients seem to be recovering faster after the Avatar, there's probably lower cost because people are getting out of the hospital faster. So that costs the healthcare care, the sort of health institutions much less money if they're not paying for a 3-day hospital stay anymore. The basic care that we provide in terms of the patient education, pain management, there's absolutely no difference in cost for any of that. It's really just how you organize it and how you talk to the patients, and it costs nothing for them. The implant cost is the same. The cost of the operating room is the same. The surgeon fee is exactly the same because it's based off of a code that's negotiated with the insurance company, which is just based off the operation that you do. So I would say, if anything, it probably costs nothing different for the patient. It costs the insurance company less.
So if we were to kind of summarize that you evaluate a patient, there's some indications that the replacement would be appropriate in whatever the hip, knee, or shoulder. You put them into your activation list. You start to educate them about what the expectations of them are going to be from the nutritional aspects, the prehab, the weight loss as indicated, the extra nutrients, vitamins that they need to take. provide the spreadsheet of medications and the pain management that they're going to do, make sure that their home environment from a tripping hazard, fall hazards are set up, their support systems from people are appropriate and in place, that they don't have any medical complications that are going to warrant extra care in the hospital, get that complete buy-in from that. Then they have the surgery, and you're seeing them taking a little less medication afterwards as compared to traditional approaches. You're seeing oftentimes a slightly improved ability to get away from assisted devices like walker and crutches sooner range of motion and strength gains and function, with very positive and happy outcomes that possibly in some cases could cost a lot less. Does that pretty much sum it up right there?
Yeah, I think that was an excellent summary. I really don't have a lot to add because you pretty much nailed it. What's been interesting for us to see is, 4 or 5 years ago, if you mentioned to a patient that they can potentially go home the same day as their joint replacement, that idea just seemed completely crazy 4 or 5 years ago. And now when you mention this to patients, their eyes kind of light up, they're excited about it. And so I think part of it is, this has been a trend that's been increasing around the country. People are probably aware of it. People may know people that went home the same day afterwards. And so this is no longer, like a crazy concept to send people home the same day. I do think that there may come a time in the future where, this becomes routinely a same day surgery. Right now, if you look at the statistics in our office, in our practice, we probably on any given day send anywhere from 30 to 70% of patients home, and it just depends on who's on your schedule for that day. And so our overall average is probably 50 to 60% of people are now going home the same day, and that's all comers, whether you're 45 years old and had early arthritis or you're 87 years old. And even the patients that do stay in the hospital, it's very rare that they're in for more than 1 to 2 days unless we know they're going to go to an inpatient rehabilitation facility. And that percentage of patients has dropped from, probably 40 to 50% 5 years ago down to 10 to 15% now. So all of these things have been, expedited just through better organization of the care. And it's just interesting now when you tell patients it's no longer necessary to spend the night in the hospital, after hip, knee, or shoulder replacement. A lot of people are really excited about the idea of going home now, whereas 5 years ago people just thought that idea was insane.
So if a patient wanted to find out more about this, have an evaluation, discuss this with you guys, or a physical therapist wanted to refer their patient to you guys for a consultation, how would they go about doing that?
Probably the easiest way is just reach out to our office, 603-431-5858. We also do on our website have an appointment request, so people can submit a request for appointment by email. And that actually comes not just to our receptionist, but it also comes directly to my email. So I can see these emails and oftentimes respond to people directly. And sometimes if people just have questions, I had somebody email me today about what I thought the best socket component was in shoulder replacement, and he just wanted a personal opinion submitted through our website. And we love that stuff. We love to provide patient education, and so that's always a good venue, particularly for people who may not want to, get tangled up on the phone or with phone messaging systems. The website works very well. Our website also has information on our avatar process and on the patient education modules that we have on there. And so that's another way that patients can learn about it. And we have a blog on our website where we have several entries, and there'll be more to come in the future that sort of map out what the avatar process is. And even for patients who are having surgery elsewhere, they're welcome to come onto our website because, the way we look at patient education is, we want everybody to do well. Even if you're having your surgery with another physician, if the education that I can provide will help you have a better outcome, that's a good thing. And so we're happy to share this with anybody.
Well, it sounds like you truly have a patient-centered practice, a patient-centered approach to seeing an extremely positive outcome, best that you possibly can, researching all the beginning to the end, the education, making sure all the stopgaps based on what the research shows to reduce any unwanted outcomes. And not only that, but promote the best outcomes. For that, the Seacoast is really grateful to have somebody like you and your colleagues around to be able to provide such top-notch evidence-based care. We certainly thank you for that, and we thank you for today, and we appreciate your time, and we learned a lot.
Yeah, it's been a lot of fun for us. I mean, I think one of the things that's been the most fun for us is just seeing how well patients do. For us to be able to spend the time with patients, educate them, get them involved in the process, do the operation, follow them through, navigate their care process, and see the results that they can achieve. You know, as you know from your work, it's just hugely gratifying when you see patients on the other end sending you pictures of them on a ski slope or on top of a mountain hiking or swinging a golf club. You know, that's what it's all about for us. And so whatever it takes to get people there, that's our commitment. So it's been a lot of fun. Thanks for inviting me to this session. It's been great.
Great. Thank you very much.